Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of lipoprotein A. Dr. Travis Brown, I'm noticing a bit of a theme in the topics you're covering. This one also intersects with cholesterol in the blood, etc. Are you trying to send messages to me?
Well, this is messages to me as well. We are getting of the age where you start to go, well, what's cholesterol? And then people start going the next level. What's good and bad cholesterol? And then you said, I was seeing my doctor of, my cholesterol profile. Look, this is an area that, to be honest, is a little bit confusing at times. And the reason it's confusing is because there's a lot of proteins here and lipoproteins, and it's very easy to get confused. And as an example of this, there's something that's called apolipoprotein A1. Now, that's a structural protein found in HDL, which is a good protein.
Okay.
So if you want that, if that's elevated, that's a good thing for you. But then you have apolipoprotein B, which is the primary structure of protein in LDLs and VLDLs, the bad proteins. So if that's high, it's bad. And then you've got this one, which is lipoprotein A, which is the topic of discussion today. And so it can be actually quite confusing because, doctors could write one thing that's very similar. If they've got the wrong alphabet at the end of it, they've requested a different test, and it can be a completely different meaning in cholesterol.
And that's where you go apoplectic.
And that's the challenge for doctors. What does this result mean? And look, lipoprotein A, it was actually discovered in the 1960s. This was by a Norwegian geneticist, Kåre Berg, and he was studying the particles and proteins involved with cholesterol and transportation. And look, what he found was that that some patients had this additional protein on LDL. Now, ended up becoming named. It was initially named apolipoprotein, so that makes it even more confusing. But in time, we've begun to know this as lipoprotein A. Now, the challenge with this is understanding that lipoprotein A is actually genetically determined.
Oh,
and so patients could have these identical cholesterol and lipid profiles, but if one of them had a high lipid protein, they actually had a higher cardiovascular risk factor for disease. And so levels were unresponsive to diet, environment, medications, and so this became known as pretty much a non-modifiable risk factor determined by your genetics.
yes.
And so we know that about 20% of people have an elevated lipoprotein A, and so these people actually have an increased risk of cardiovascular disease.
And there's not a lot they can do with it with exercise and diet, or am I jumping the gun?
No, there's nothing at the moment that can be done about this, and this is why it kind of has been ignored for a long time. Like, people have gone, well, can't change anything, so, why test? And it fell out of favour. But there's some new cardiovascular guidelines coming out, particularly from the US, but also Europe, that says patients should have this tested at least once in their lifetime to see what their cardiovascular risk factors are. Because whilst you can't change it at the moment, you can change the other cardiovascular risk factors to reduce your overall cardiovascular risk disease profile.
So if it was an orchestra and you happen to have a violinist who is really loud, but there's nothing you can do about it, you can modify the other instruments around it to sort of deal with that.
That's right, and you can make an adjustments, and this is where it's just
put them in another room.
You can try, but this is one of those things where we're starting to look at it. And again, lipoprotein A, it wasn't even something that I came up through medical school. This is something that doctors need to be aware of. And again, when they start coming out in guidelines, it's important to know about. Now, the really interesting quirk about lipoprotein A, though, is there's a twist in evolution of lipoprotein. So it's in humans,
Yep.
It's in sort of the old world monkeys and great apes, and then there's not in many other animals except for one, the hedgehog.
the hedgehog.
So this protein's actually found. So if you want to find, little quirks of this, in evolutionary standards now, we're pretty far removed from the hedgehog, but they have this same protein in their blood. And so this is just sort of that weird, well, why would we produce this lipoprotein A? It's in our atherosclerosis or atherogenesis. And so some people believe it's in the hedgehog because of, hibernation. No one actually knows why, but there's just this quirk of evolution that this protein that we're testing for, and this lipoprotein A, is found in the hedgehog. And so it's just a sort of that little quirk. And again, it's just one thing that people will find interesting when you do searches for this. So, but again, the reason why we're discussing it is it's important for doctors to know about. It's a test to be considered when you're actually assessing a patient for, overall cardiovascular risk. And so that's why we're discussing it today. It's something to be aware of and something that we continue to test for and make available for patients and doctors.
Dr. Michael Page is a chemical pathologist and Chief Executive Officer at Clinipath in Western Australia. Michael's a senior lecturer at the UWA Medical School and an examiner for the Royal College of Pathologists of Australasia. He's also the immediate past president of the Australian Medical Association, WA. Michael's a returning guest on this Medical Life podcast. Michael, welcome back.
Great to be back with you again.
And of course, now you're no longer president of the AMA. You've got more time to do podcasts like this.
Absolutely right. Any opportunity, I say yes.
So for today, we're talking about lipoprotein A. Let's start with the definition. What is it?
Look, lipoprotein A or lipoprotein little a is a particle in our blood that we can measure that's made mostly by the liver. And it's a lot like the more familiar LDL or low-density lipoprotein. Many people who've had their cholesterol tested will be familiar with LDL or LDL cholesterol, which is the cholesterol content of LDL particles. Lp(a) is a lesser known but very similar particle. It's not included in a routine cholesterol test. But it is very important as a cardiovascular risk factor, in other words, a causative, as a cause of heart disease, and awareness about it is gradually growing.
What role does lipoprotein A play in atherosclerosis?
Yeah, much like LDL, Lp(a) or lipoprotein A, or as we abbreviate it, Lp(a), delivers cholesterol into the walls of our arteries, which is the starting point for atherosclerosis. So you need cholesterol to form atherosclerosis, which is the fatty and inflammatory plaque that forms in the walls of our arteries, in the heart, and elsewhere in the body. So Lp(a) particles, like LDL particles, get trapped in the wall of the artery. The cholesterol gets released into the atherosclerotic plaque or into the beginnings of the atherosclerotic plaque. They cause inflammation, which is a key part of atherosclerosis and the formation of atherosclerosis, and also the instability of atherosclerosis. The cause of most heart attacks is an atherosclerotic plaque in the arteries of the heart rupturing and causing a clot, and Lp(a) is something that promotes that process.
Do we know how or why it equates to a patient's cardiovascular risk profile?
It's around its similarity with LDL. So LDL, we've known for many, many years, is a cause of atherosclerosis. Lp(a), it's been less certain over the years whether it's a true cause or not, despite its physical similarity with LDL particles. But some really cutting-edge genetic techniques over the last 10 or 20 years have really helped us to solve the problem as to whether Lp(a) is truly causative of heart disease or whether it's merely a bystander. So there have been various theories over the years as to whether it's a cause of heart disease or, in fact, people with heart disease just make more of it. So what we would call reverse causation. That's been more or less excluded through this genetic technique called Mendelian randomization, whereby you can take a bunch of people with high lipoprotein(a) that we know is genetically determined, and therefore they've had it since birth, and work out whether they have higher probability of having heart disease, and indeed they do. Because Lp(a), and we can do that because Lp(a) levels are so highly genetically determined, which is a bit unlike LDL. So LDL, yes, there are people with genetically determined high LDL cholesterol, in particular familial hypercholesterolemia, but by and large across the population, LDL cholesterol is more likely to be determined by diet, hormones, environmental factors, as well as genes, whereas Lp(a) is much more genetically determined. You've either got it or you don't.
Do we know, like when you say it's genetics, do we know is it autosomal dominant or autosomal recessive? Do we know any of that about it?
The genetics are fascinating. You've got two populations of Lp(a) particles. So each of us has two populations of Lp(a) particles. One expressed from the gene we inherited from our mother and one from our father. There's this relationship between the size of your there's this relationship between the size of your Lp(a) particles and how high the concentrations are in your blood. If you make bigger particles, your concentration tends to be lower because when they're made in your liver cells, they get trapped before they get excreted into your blood. If you've got smaller particles, when your liver cells make them, they're more likely to make it out into your blood. But there's a whole range of sizes. You could have small, large, or somewhere in between. So if you inherit the gene from your mother that gives you large particles and the gene from your father that gives you large particles, then you'll have low concentrations. If you inherit smaller particles that are genetically determined, then you'll have higher concentrations. But you could be somewhere in between. If mum's got large and small particles because her two genes are one's determining large ones and one's determining small ones, she'll have concentration somewhere in between. Your dad might just have large particles, so his concentration's low. So then the gene that you get from your mum is going to determine. So it's co-dominant, I suppose, in the simplest terms.
Excuse me, Michael, I don't want to disrupt your train of thought, but if you had to choose to be at one end of that spectrum, would you rather have large and the liver is bearing the brunt, or small and the system?
Yeah, you want to have large particles because then your plasma concentrations will be low. Okay. And that's most of us, 4 out of 5 of us will have larger particles and therefore lower concentrations. And 1 out of 5 of us will have the small particles and therefore the higher concentrations. It's largely true. This is largely true. There are some other genetic factors other than size that determine how high your concentration is, but that's the main determinant.
Who should be tested and how often?
Interesting, the guidelines vary a little bit around the world on this. The most recent American dyslipidemia guidelines that have been endorsed by about 600 different, not literally 600, but it seems like that when you read the article, by many, many peak bodies in America in 2026 have recommended that every adult has their Lp(a) measured at least once in their lifetime. The European guidelines from a few years ago said the same thing. The Australian guidelines, from also a few years old now, have a more targeted approach in terms of measuring Lp(a) in people at particular risk levels. But, I think the direction of travel is really measure it in everyone. 1 in 5 people has an elevated Lp(a) level, and knowing whether or not you've got high Lp(a) is important for working out your overall cardiovascular risk and what you can do about it. Although there are no treatments, and I'm sure we can get onto this, although there are no specific treatments available for lowering Lp(a) specifically, there are nonetheless things that we can do about the risk associated with Lp(a). So, my view increasingly would be we should just measure it in everyone, but that's not yet what the current Australian guidelines say.
So when they're talking about increasing cardiovascular risk factors such as lipoprotein little a being elevated, are they just talking about heart attacks?
Not only heart attacks. So the major thing we always think about is atherosclerosis in the coronary arteries, which Lp(a) does promote, and that leads to atherosclerosis in the coronary arteries is what causes most heart attacks. Lp(a) does also cause aortic valve stenosis, so the big valve that takes the blood from the left ventricle of the heart out to most of the tissues of the body. That valve can become calcific and stenosed, in other words, narrowed, which can be a problem, of course. But also other, atherosclerosis can form in other parts of the body. It can lead to stroke. It can lead to renal disease. It can lead to peripheral vascular disease. In other words, reduced blood flow to the legs or other parts of the body. So, so there's more than just about the heart, although that is, in terms of the attributable mortality to Lp(a), heart attack, I suspect would be the biggest burden of disease.
Now, gets into that confusing area where we've got lots of names that are very similar when we start looking at, like, lipoprotein. And there's things like, apoprotein A1 and apolipoprotein and everything. Is there any relation? Are these naming conventions just out of control and we're just not sure what's going on?
Yeah, I mean, someone back in the 60s decided that they would discover all these things and, as a form of torture for future generations, give them ridiculous names that make no sense to anyone. Other than a biochemist or a research scientist. So it is unfortunate. Lipoprotein little a is a shocking name, absolutely shocking. If I could do one thing, it would be to change the name to something a bit more intuitive.
Hear, hear.
And it causes all sorts of havoc for doctors. It causes havoc for pathology laboratories where, they're not sure what the test is that's actually been requested because maybe someone's written it slightly incorrectly, or so it's a genuine problem. Look, So lipoprotein little a is the particle that we're talking about. It's got a little bit on it called apolipoprotein little a, which is the protein component that makes it special. There is something else called apolipoprotein capital A1, which is part of HDL particles, which are part of a standard blood test. HDL particles carry HDL cholesterol, the so-called good cholesterol, although let's not get into that because that's not a very useful term either. There's nothing that good about HDL.
Okay.
And so, and then there's apolipoprotein A2, there's ApoC3, which is now a target for triglyceride-lowering medications. These things are shockingly named. Look, what do you want me to say? I mean, it's not, don't shoot the messenger. That's all I can say.
I've just been doing a lot of work with heritage riverboats, and I learned that, how we have port side and starboard? Port was originally called larboard. And so imagine telling the engineer larboard or starboard. So they soon changed it to avoid confusion.
We're not going to change anything, Steve. I don't care how much it makes sense. So sorry about that. Yeah.
Well, I remember when I played cricket as an under-12, being told you don't say no to not run because it sounds like go. You say stay or go or something like that. I can't remember, something like that. So it is important. Clarity of communication is important.
It's important. Now, there are actually, on that matter, there are some other tests that I want to throw at you. So there's tests for lipoproteins, there's lipoprotein electrophoresis, and there's lipoprotein X. How useful are these tests? Where do we sort of order these tests? What are they for?
So this is where, so throw a bit more terminology in. Lipoprotein X is... is not even a lipoprotein. So people with a certain type of liver disease where there's an obstruction to bile flow in the liver, little bits of cell membrane sort of break off from the liver and they get cholesterol packaged into them and float around in the bloodstream, but they're not true lipoproteins. They're this cholesterol-carrying little blebbed-off bit of cell. And so people with liver disease, sometimes if you measure their cholesterol, it can be sky high and it looks like LDL. Well, it's measured as LDL cholesterol, so it looks like they've got these ridiculously high LDL cholesterol concentrations, the sort of thing you'd see in the most severe forms of familial hypercholesterolemia. But in fact, they're not true lipoproteins. And you can either do lipoprotein electrophoresis, which is a method where you know, it's a very manual kind of old-fashioned laboratory method where you have a gel and you run the proteins along, you run the lipids along the gel and you work out where they land after, you know, putting an electric current across the gel. We don't really tend to do that anymore. The best way to work out whether someone's got lipoprotein X, if they've got really high cholesterol and you're trying to exclude it, is to measure apolipoprotein B100.
That's what I was going to say.
which is a component that's unique to lipoproteins, including LDL, including including LDL, including lipoprotein A. They've all got ApoB. So if you measure their ApoB and it's low, but their cholesterol is extremely high, they've got liver disease, then you just can safely assume that it's lipoprotein X.
There we go. So that's all good.
We could write a song about this.
Well, I think Steve may. You never know.
I was thinking of changing the category from medical to comedy for this podcast.
Maybe Tom Lehrer style, yeah.
Yes.
And just from a sort of a fee perspective, is this likely to be covered under Medicare soon? Because there is an out-of-pocket cost depending on which state you're in. Is this likely to come under now with recommendations changing, do you think?
Yeah, so I mean, I guess cutting back to the chase, all the terminology nonsense aside and back to the practicality, Travis, you know, given the direction of travel, which is that, you know, probably every adult should have their Lp(a) measured because 1 in 5 will have a high level and it does modify your risk and how you see your own risk of a future heart attack. The lack of a Medicare rebate for it at the moment is a barrier. It's not a huge barrier. I mean, the reality is people pay for medical care of all sorts. They're not used to paying out of pocket for pathology tests, so it seems a bit unusual that there's no rebate, though of course people will pay out of pocket on radiology, on specialist appointments, on GP appointments every day of the week. So I don't think it's a huge barrier. You know, usually the fee for a lipoprotein A test in Australia is, you know, somewhere between $40 and $60. And you only need to do it once. If it's low, you don't actually need to measure it again because it's so highly genetically determined, it's unlikely to go up or down. So you know, in the scheme of things, it's not what you'd call an expensive test, but not having a Medicare rebate is still a barrier. Not everyone can afford the test. So there've been a couple of attempts to have it listed on the Medicare benefits schedule. Hasn't quite got there yet, but it will. I'm very confident that it will, especially as we get closer to having medications that specifically lower it.
Ironically, that's about the same cost as a packet of cigarettes.
Well, indeed.
Let's pause. I'm going to get Travis to write out a blood test form for me, and we'll regroup in a moment to dive further into this topic. We're continuing our discussion with Dr. Michael Page now as we look at the testing of lipoprotein A, or little a, I've now learned to say. So lipoprotein a is described as a non-modifiable risk factor for, what's that word, Travis?
Atherosclerosis.
Yeah, that's right. Why test, Michael?
Yeah, it's interesting. Non-modifiable is true in the sense that we can't modify its levels, but we can modify the risk associated with it. So I would argue that it's not truly non-modifiable in that we can do things about its risk. So if you've got a lipoprotein A level that's high, let's say 400 nanomoles per litre, we say, okay, that's a risk factor. Can we lower that down to 100 or 50? No, not yet. Hopefully soon. So it's non-modifiable in that sense. But if I had a lipoprotein A of 400 nanomoles per litre, I would be at a much, much increased risk of having a heart attack in the next, let's say, 10 to 20 years. And so what do I do about that risk? Well, in general, the use of a statin to lower my LDL cholesterol is going to be one of the first line options, other than, of course, diet, exercise, paying attention to other risk factors. Do I have diabetes? Do I have high blood pressure? All those other risk factors that we need to think about. Diet and exercise, which won't, again, change the Lp(a), but will modify my cardiovascular risk. After all of that is said and done, if you've got a very high Lp(a), then lowering your LDL cholesterol is likely to be beneficial, even if it's at a normal level, because there's no level of LDL cholesterol below which we don't see any further reduction in cardiovascular risk. In other words, if your LDL cholesterol looks normal, let's say it's 2 millimoles per litre, which usually wouldn't raise any alarm bells, dropping it down to 1 is actually going to reduce your cardiovascular risk. So if you've got some other thing driving your risk, which is not the LDL, lowering it in spite of its normality is still going to reduce your cardiovascular risk. So that's what most guidelines, perhaps won't get into the nuance of all the different risk levels and what the recommendations are around what you do. But in general, there are plenty of things you can do about the risk associated with Lp(a), even if we can't yet specifically lower it with medication.
So you mentioned a level there. So the greater than 400, so that's high risk between 400? Is that the sort of cutoff area?
Oh, look, we call normal anything less than about 75 to 100, So if you're less than 100 nanomoles per litre, you probably have no increased risk associated with your Lp(a). Now, that doesn't mean it's protective in terms of other risk factors. If you've got diabetes, if you've got high LDL cholesterol, if you smoke, all those things, it's not going to protect you to have low Lp(a), but you don't have that additional risk factor. So above 100, the risk increases in a sort of fairly linear way. In other words, the higher it is, the higher your risk. It's not a binary thing where either you've got high levels or you don't. The higher it is, the greater your risk is likely to be. And it runs all the way up to, I think the highest one I've seen is about 850 or something like that, but that's extreme. The ones you tend to see are between 100 and 400. Once it's above 200, that's when you really start, I think, getting more concerned about it. There's no, again, it can be difficult, like anything with cardiovascular risk, working out someone's risk and what to do about it is highly individualised. There's no magic cutoff that says, okay, everyone with a Lp(a) level above X should be on Y treatment. But having said that, a level above 400 is something that really makes you sit up and take notice. That person is likely to be at greatly increased risk, perhaps 4 to 8 times what they otherwise would be. And maybe between 100 and 300, it might be sort of 2 to 3 times the risk, So it's a linear thing. The higher it is, the worse off you're going to be in the long term.
When doing some reading on this, I just found chemistry said that it may even be an acute phase reactant, though. So when you actually test can be significant. Is that something you've come across?
Acute phase reactants, are things that go up or down in the acute illness setting. And so the most common one that's talked about with lipoprotein (a) is post-heart attack, because, of course, that might be a time that someone measures it. Someone comes into the hospital with a heart attack at the age of 40. It seems a bit unusual because they're quite young, and so the cardiologist or the other doctors in the hospital check their lipoprotein (a) and they find it to be high or they find it to be low. So that is a common setting for Lp(a) to be measured. And it does go slightly up with a heart attack. Not long term, it goes up for a couple of weeks and then comes down again. But it's only pretty marginal. So, if it comes back and it's low, well, it's low. If it comes back and it's high, it's probably high. If it's somewhere around the borderline, then maybe you want to measure it again a month or 2 later. It's not a huge effect. It's not so much of an effect that you could throw the result in the bin. It's probably going to give you some information. Of course, you're better off measuring it long before someone had that heart attack. Yeah. So primary prevention is of course, better than secondary prevention in so many ways. But nonetheless, plenty of people have it measured after their first heart attack.
Is it fair for me to say, because I am being dutiful, Michael, with my GP every year or 18 months, I'm having my blood checked and everything. Would he have done this as a matter of course, even though it hasn't come up in conversation, or is it not something that's done? as a matter of course?
It's unlikely, Steve. I mean, not that I know who your GP is, of course, or what their practices are. And this is not any judgment on GPs. I mean, GPs have 600 different things to think about every day, and Lp(a) has flown under the radar for a long time. And it's only been in recent years that we've understood exactly what it does to cardiovascular risk and have some clarity around what to do about high levels in any given individual. The plethora of different guidelines that sometimes conflict with one another doesn't help. So what we really need is clarity in primary care, for primary care, around in whom to measure it. And again, I think, more rather than fewer, and what to do about the results if it's high. And that's the real bridge, is that no GP or other doctor wants to measure something if they don't know what they're going to do with the result. So, and I think we who work in pathology have a significant responsibility there to help guide, given that it's a relatively new test. Yes, we've known about it since the 1960s, but it's newly, I suppose, being newly recognised anew as an important thing to measure. We've then got a duty, I think, to provide guidance as to what the results mean, and perhaps lead our clinical colleagues towards the right type of information to help them make decisions about the patient, with the patient who's in front of them.
Is there any treatments or sort of effect on the horizon that may be sort of lowering it, or that may not even affect it, but is there anything that's on the horizon with regards to treatments for this?
Sounds like a leading question, Travis, because the study that's going to report by the end of this year hopefully is called Horizon. So that is very much on the near term horizon.
I'm not paid by them. That's all good.
Yeah, I hope not. Look, there's a few phase 3 trials going on at the moment of medications that can lower Lp(a) quite significantly. Horizon is a study of a medication called pelacarsen, made by Novartis, and that is it's a medication that blocks the production of apolipoprotein A and therefore prevents you making Lp(a) particles. It's given by injection, and it reduces Lp(a) concentrations by 80 or 90%. So very, very effective in lowering Lp(a). But it's the first time a study has been done to see whether lowering Lp(a) with medication, specifically lowering Lp(a) with medication, actually reduces the risk of a heart attack or other cardiovascular outcome. Now, if it doesn't, there's going to be a lot of sad people, including me, that staked our reputations, if you like, on the whole theory that reducing Lp(a) should reduce the cardiovascular risk. So this is one of the most keenly awaited studies across medicine. The population of people in that study are people who've already had heart disease, so it's a secondary prevention study. So it's not necessarily going to tell us whether lowering Lp(a) in people who've never had a heart attack or any kind of cardiovascular disease reduces their risk of future heart disease. That evidence will come later. But in the first instance, if we can see that lowering Lp(a) prevents people having a second heart attack, that will be very, very powerful in really proving beyond any doubt the hypothesis that lowering Lp(a) will reduce cardiovascular risk.
Now, I haven't had a heart attack yet that I know of, and I believe in cutting things off at the pass. So if I'm going to bring this up as a point of discussion with my GP, if he is so inclined and we do a test, are there any websites that doctors can use as a reference when they're interpreting Lp(a) results, especially if maybe their pathologist has not necessarily developed really helpful interpretive results?
Yeah, look, unfortunately at the moment, most of the risk so there are these cardiovascular risk calculators which you can use. There's an Australian one, there's all these ones around the world, and you can plug in your blood pressure, plug in your cholesterol, plug in your age, gender, whether or not you smoke, various risk factors, and determine your risk over the next 5 years or 10 years of having a heart attack. And a lot of them are based on very, very old data. Most of them don't include LP(a), and so they're rough tools that you can use to just guesstimate, and really they're useful as a patient, almost as an aid to the consultation. So the GP can say to the patient, well, here's your 5 or 10 year risk. One of the other shortcomings of those calculators is they've got such a short horizon, 5 years, 10 years. I'm in my 40s. If I want to know my risk of having a heart attack, is 10 years enough of a timeline to give me useful information? Or if I'm in my 20s, even less so. You don't want to have a heart attack when you're 50, 60, 70, or even 80. So there are a couple of risk calculators more recently developed. There's one at lpaclinicalguidance.com, which I find quite useful. It's based on a large data set from the United Kingdom called the UK Biobank, and does include LP(a), and you can use it. It will give you a risk estimate out to the age of 80. Is it accurate? We don't know. Is it applicable to an Australian population? We don't know. We just don't have those data. But as a general guide to helping people understand their risk, I tend to think that type of calculator is quite useful, and it does include LP(a) as well as all the other risk factors.
Travis, if you remember, we should put that link in the show notes.
Yep, sounds good.
My GP did do something like that, I recall now. The result was dystopian, I think it came back with. Michael, in closing our conversation, I have been picking on my poor GP. Not really, I love him. Do you have any final thoughts or advice for doctors on lipoprotein(a)?
Look, I think this is the new wave of cardiovascular prevention. There's almost no doubt. These medications are. Look, I don't have a crystal ball. I don't know whether the studies will show that they're useful or not. We're all hoping that they are. We're all predicting that they will be. But of course, the proof of the pudding will be in the eating. But nonetheless, LP(a) is important to measure. It does strongly predict risk. It is very likely to be the next wave of cardiovascular prevention. And so my advice to any doctor or patient out there would be to learn about it, read up on it, and start checking it. The key really is around what to do with the result. And I think there's a lot of work to be done around guidelines that are practical, readable, interpretable in primary care. We don't really yet have that in Australia. We don't have any really clear guidance for our primary care colleagues as to what to do with these results. And so it's sort of incumbent on those of us who are interested in lipidology and those of us who work in the pathology setting to help our clinical colleagues to interpret these results and aid them in having the conversations with their patients about the results.
Dr. Michael Page, in stark contrast to the naming conventions of your field, thank you for bringing clarity to this topic and joining us on This Medical Life.
My pleasure, anytime.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.